The first is Dr. Virginia Winn, who will talk to us about preeclampsia, who is at risk, and can we figure out why? Dr. Winn is an associate professor in obstetrics and gynecology. I'm very pleased with that because I get to see her every day. She's also the director of reproductive and stem cell biology, and she's really been a model clinician and scientist for our department and I think for Stanford. She's a maternal fetal medicine clinician and runs a lab that is growing by the day focused on the placenta, preeclampsia, and vascular health. She has very broad collaborations, and her multidisciplinary work, again, is a model for what we do, and she is a fantastic and appreciated mentor. You'll appreciate her enthusiasm. Dr. Winn, please.
All right, good morning, everyone, and thank you for the introduction, Dr. Subak, and thank you very much for the incredible talk. I love the message of earlier the better, and that we realize that our whole life course actually starts at even preconception in terms of our health. So today I'm going to address preeclampsia, which is a condition specific to pregnancy, and who gets it and why. And these are two questions that really fuel a lot of the work that happens in my lab. Most people in the room probably are aware of the condition of preeclampsia, but it is something that impacts 3 to 5% of pregnancies in the U.S. and up to 8% globally. So this is impacting 8 million women-infant pairs per year around the world. It is a condition where the woman's blood pressure increases, she begins to spill protein in her urine, or has other signs of end organ damage that begins in the latter half of pregnancy. It's a cause of maternal mortality, as well as really impacts the rate of preterm birth, particularly in the U.S. We know that the placenta is central to the disease process, and the only definitive therapy we still have today is actually delivery, and that's what leads to that increased risk of preterm birth for those women who develop it in the preterm period. There has been a lot of work, and there is a lot of understanding of aspects of the pathogenesis of preeclampsia. Particularly central is an understanding that there's an endothelial dysfunction and an enhanced immune response that is likely really driven by the placenta. So today I'm going to attempt, might be a little ambitious to do two tales of preeclampsia, but I wanted to highlight, because these are two projects that are answering the why, who gets preeclampsia and why, that have both been funded by, in part by the MCHRI. So the first project is early prediction of preeclampsia using machine learning. And given my tech savviness that you've already appreciated this morning, you'll realize that this is also a very interdisciplinary program. I bring the clinical perspective, the biological perspective, and Ivana Maric brings the incredible mathematical and computational science aspect to this project. It's also in collaboration with David Stevenson, Gary Shaw, and Andrea Montanari. The second tale that I'm going to talk about today is my project that was funded by a Faculty Scholar Award that helped fund this pregnancy outcomes following infertility and endothelial cell health. And this is a large collaboration with several REI colleagues, Frauke and Valerie, and a pediatric cardiology collaborator, Seda Tierney. So the first tale I'm going to call the obstetrician's crystal ball. And so early prediction of preeclampsia would be extremely valuable. And this is well recognized, and many people have attempted to answer the ability to predict preeclampsia. First of all, it gives closer monitoring of high-risk pregnancies can be identified, which helps with resource, particularly in low-resource settings. It would help refine, and personalize more preventative strategies that we currently do have, which include low-dose aspirin. And for me, it's actually really important to help increase case selection for clinical studies. The NIH has spent a tremendous amount of money on very large clinical trials for preeclampsia prevention. With an incidence of 5%, and you don't know who's going to get it until the second half of pregnancy, you're enrolling thousands of women for looking for a 5% rate. So if we could predict who's going to get it better, it would help advance the field in terms of clinical care. So what are the challenges of predicting preeclampsia? First of all, the pathogenesis is not completely understood, and it's likely there's multiple pathways, and preeclampsia is really a syndrome. And so it is hard to predict something that is complex, and you can get there in many different ways. I am envious of trisomy 21 in that regard, in terms of the etiology, and it helps with that piece. We know that there's a wide variety of risk factors to get to preeclampsia, and these risk factors are also highlighting probably these different pathways of getting to preeclampsia. And so there's been multiple phenotypes used to identify, characterize preeclampsia: early onset, late onset, mild preeclampsia, severe preeclampsia, placental-driven, maternal-driven, angiogenic imbalance versus an immune rejection. There's been a lot of attempts to try to understand this syndrome of preeclampsia. And in the US, we still do not have a routinely implemented prediction model for preeclampsia. So the goal of this project was to develop a model for preeclampsia using machine learning. And we received a new idea grant from MCHRI to attempt this. And we wanted to develop a tool that could be deployed easily into routine prenatal care early in pregnancy, and utilizing just the fundamental information we're already gathering. Can machine learning take this information and see patterns and risks that the clinician does not see? I like to think about it as it's that seasoned clinician that's seen these patterns over 4 decades of work, and they understand the risk of their patients. Can machine learning take that 4 decades of seasoned intuition and give it to us via machine learning? So machine learning for this problem is well suited because we're going to be analyzing high dimensional data. It's capable of extracting those patterns from data and our patients. Can be performed automatic variable selection. So it's agnostic. We are not predetermining what we're going to look at. So the bias is removed in that regard. There's no assumptions about the data. It's not Gaussian distributed, the correlation relationships. There's no assumption about the data when you approach it this way. And it can handle a certain amount of missing data. And that actually became more obvious a need as we got into the electronic medical record. So our approach was to utilize all the variables that are available in the early prenatal care. We obtain a large panel of standard labs, histories for the pregnant women, and can machine learning see patterns in all of that that haven't been identified before. So the idea was to take the routine prenatal care information, make a prediction of preeclampsia, and look at the outcome for that pregnancy. And so Ivana used 2 methods to approach this, elastic net and gradient boosting, and then to compare how those performed compared to a standard model of logistic regression. So this is elastic net. You can think about being able to put in all your variables and then decide how wide or how narrow your netting is going to let variables fall through that are going to be used in the prediction model. And so you let the data decide where that inclusion is rather than on a one individual basis. So for the mathematicians in the room, you determine what the lambda is via tenfold validation, which is looking at the log of the lambda to the bimodal deviance. For those of us who have no idea what that means, it is looking at if you change your net size and look at the ability of the prediction, where do you find your sweet spot to optimize both of those parameters. Ivana, I hope I did that justice. For this, you actually have to input missing data. In contrast, gradient boosting is another approach where you build a simple trees sequentially. So if you think about your covariate as being preeclampsia outcome, you fit a decision tree to explain who was at risk and who wasn't. You're not going to be 100% perfect. Whatever the error rate is, that part that you couldn't predict well, you take that information and do it again with that to figure out the prediction. And if you do this sequentially and sum these all up, you get a better, a stronger model for the prediction. And the beauty of this is you don't have to impute missing data, so it can handle missing data much better. So for this project, we used a data set here from Lucille Packard. It was patients that had delivered at Lucille Packard between 2014 and 2018. This was 16,000 live deliveries. 1,600 plus had preeclampsia or eclampsia. That was 10%. So that's actually higher than the rate I quoted you, but that is because we're a referral center and have a much higher risk population. And we looked and got the medical history and the outcomes defined by ICD-9 and 10 codes, and then also had the labs and the medical history. So the electronic medical record, I thought this would be great because we get this information on every pregnant woman. I did not expect there'd be missing data. This was a huge issue. Part of it is just how you get to the electronic medical record and that people deliver at Stanford who are getting care at other clinics and how it gets put into the Anyway, we went back and just used those records where we had at least one vital sign in the first part of pregnancy. So we ended up with over 5,000 live births to work with, of which 500 plus were preeclamptic. And again, you can see it was a 10% rate. So we haven't biased the missing data issue. So Ivana did her magic and looked at prediction models for preeclampsia using just the standard prenatal care. And what came out of that is these are the top features: hypertension, history of preeclampsia, insulin, high blood pressures, multiple pregnancies, aspirin. These are all things as a clinician, I'm like, yeah, where's the new stuff? And also, I'll note here, pregnancy conceived by assisted reproductive technology also fell out as increased risk of preeclampsia. And then there was things like height. And Ivana's actually gone on and looked at the large California database and confirmed actually low height, higher risk, tall, lower risk. And it's across all ethnicities. So this is why I think this is like the 4 decades of the clinician. Takes these patterns, all of these things we know are associated, but the question is how much and in what combination? And for that individual patient, how does it all come together in terms of an actual probability for that participant? And like everybody else who has looked at early prediction, early onset, it always fares better. It's easier to predict who's going to get early onset preeclampsia compared to late onset preeclampsia. So these are actually really nice area under the curves, but they are actually not really that different than what other people have been able to do. And so there's a number of studies that have good area under the curve predictions. On all of them but one, follow-up validation studies, it never performs as good as it does in the original cohort. The issue that is amazing to me is we did this on messy data, retrospective electronic medical record with no Doppler, no specific blood tests, and it performed just as well as these prospectively collected, complete, curated data sets. And I think that's the strength of what we see with what machine learning can provide. So if we just look at a couple of examples, patient 1, the things in red were things that would put you at increased risk. The things in green put you at lower risk. And if we put it into this prediction model, it comes out with a score that's not the percentile, that's not the probability. I'll let Ivana explain that if anybody has questions. But she's high risk, she's low risk, high risk. And if we compare that to what is our current day status is based on ACOG, SFMM, and US Task Force, women who are at high risk of preeclampsia, we're recommending them starting on a baby aspirin at 12 weeks. So for patient 1, you'd start on a baby aspirin. For patient 2, there's actually a discrepancy between this prediction model and what the recommendation would be clinically. And patient 3, there's a discrepancy the other way. So when you look then, what really happened to these 3 patients who developed preeclampsia, the first case, a lot of risk, not much protection. Second case, actually, hypertension was the #1 risk in the model, but yet, because of the other aspects, was low risk overall. And so would have been recommended aspirin, but based on this new prediction model, you might not need aspirin. And then for patient 3, it would not be considered high risk, but the prediction model does see it as high risk. So summarizing this, we used various methods utilizing this data for prediction models. We were only using preclinical data and it compares to prospectively well-curated data. That's the piece that I found remarkable. And so we're in the process of continuing to refine this and now validate it on other cohorts to see if it can perform as well. So how am I doing on time? Okay. So tail number, I knew this was challenging. Tail number 2 is the tale of the yellow bodies and pregnancy hypertension. And what do I mean by yellow bodies? This is looking at the corpus luteum. The corpus luteum is the follicle after ovulation of the oocyte in early pregnancy, becomes a very important hormone producing structure that is yellow. And it is supporting the pregnancy until the placenta develops and takes over for support of the pregnancy. Normally you have one corpus luteum because you had one ovulation. Twins, you might have 1 or 2. In IVF, you can have multiple corpus luteum or no corpus luteum if you're doing a frozen embryo transfer in what's a medicated cycle, so a preparation and not going through a natural cycle before implantation. So the hypothesis of this project, which is actually out of a PO1 from NICHD, led by Kirk Conrad at the University of Florida and Val Baker, who was here at Stanford, had the hypothesis that the number of corpus lutea impacted your hypertensive risk. And so they had an enrollment of over 800 women, over 700 live births. This analysis was limited to the singletons with autologous embryo transfer. The populations, when you broke them down by number of corpus luteum, demographics were pretty well balanced across the groups. But what they saw was that there was an increased risk, particularly significant in preeclampsia with severe features in the 0 corpus luteum group. We're talking 12% preeclampsia where it's 5 to 6% in all the other groups, 9% when it's 2 to 4% in all the other groups for severe preeclampsia. And if you look just strictly at no corpus luteum and 1 corpus luteum, or more importantly, if you only look at frozen embryo transfers in a programmed versus a natural cycle, so you're controlling for many more factors, the risk is higher in terms of odds ratios. So the hypothesis, so I'm going to skip this piece other than to say I was fortunate enough to do an ancillary study on the last several years of enrollment of that study so that we could begin to look at the why, the biology of risk of IVF in a program cycle. How is that translating into hypertensive disease for these women? And so we enrolled women and studied their endothelial dysfunction, their endothelial progenitor cells at multiple times during pregnancy and postpartum through the lens of how many corpus lutea was present in that early pregnancy. And what we did find was that actually there are differences, even in early pregnancy, between women who've had a frozen embryo transfer in a program cycle versus a natural cycle, having worse endothelial function, having more arterial stiffness, and having fewer circulating endothelial progenitor cells. And so this is a summary of all the data that we had looked at in this small cohort. And what we found was that medicated IVF cycles, those program cycles that lack a corpus luteum, are associated with increased risk of preeclampsia and surprisingly not gestational hypertension. That a non-physiologic number of corpus luteum does impact maternal vascular parameters in early pregnancy. So suggesting that the corpus luteum may be producing products that are really important for the cardiovascular adaptation of pregnancy. And if we understood this better, and it is true that a natural cycle is really lowering your risk of preeclampsia, it would be a simple change in our clinical management that would have significant impact on mothers and babies. And so we're fortunate we just got funded in September from NICHD to actually do a randomized controlled trial to determine if it truly is true that embryo transfer in a natural cycle does not increase the risk of preeclampsia. And so I really like to thank MCHRI, the March of Dimes Prematurity Center, also provided support for the machine learning project. This is a recent picture of my lab with that new biomedical science building out front. And I'll be happy to take any questions.
Virginia, that was really great. The question about relaxin and preeclampsia risk.
Yeah.
Is it true that the number of corpus luteum also correlates with relaxin?
Yes.
And if they had corpus luteum there, but they were just not so good at making relaxin, does that also correlate?
I don't think that is known, and I'm actually not sure how we could easily get that data. Because there is clearly a correlation in maternal relaxin levels with number of follicles in like IVF stimulated cycles. But when you pull out the oocyte, you also pull out the granulosa cells that actually are needed, and depending on how much you pull out or don't pull out.
Right.
Yeah.
And then Deanna talked about the placenta. And then since the corpus luteum is sort of the surrogate for the placenta later on, do you see similar effects in the placenta later on that correlate with the corpus luteum? Is that a correlated thing?
This is I don't think anybody has actually looked at placenta through that lens. I mean, we haven't even looked at ART, risk of preeclampsia, through this lens until the last several years. So that's a very good question. Maybe we'll be able to answer it.
And then the last thing is, in the adult, does it also correlate with adult hypertension as well? I know there was some correlation.
The corpus luteum piece?
Yeah. In terms of like in this idea of, what we look at in kids also predicts the adult phenotypes as well. So people care about adult hypertension. That's
Yep.
a big issue. But can you actually look at that in the very earliest stages and then predict adult predisposition.
Yep. So in this, we have some longitudinal data from this cohort. And the one thing that is clear is that the degree of dilation or arterial tone is much lower in the multiple corpus luteum compared to 1 and then 0, and that actually persisted into the postpartum period. So I think we're just beginning to touch the iceberg, the tip of the iceberg on this. Great questions, thank you.
Just regards to the first part of your talk on
Yep.
the risk or predicting preeclampsia using machine learning.
Yes.
Can you comment on the potential use of biomarkers or cell-free nucleic acids and things like that to predict risk of preeclampsia early in pregnancy?
Yeah, so in terms of utilizing what people are currently trying to utilize those things to develop prediction models and then using the machine learning. I think that's, Ivana is so excited to think about if we had a really clean, powerful data set compared to one with all this missing data, how powerful these modeling prediction models could be. It's a balance, I think, between needing to do a test that's expensive to add into the modeling versus being able to use the modeling to be able to put together low cost characteristics and variables that are routinely gotten. But I think we are definitely moving to being able to look at a liquid biopsy, be it epigenome from the cell-free DNA, the cell-free transcriptome, even the metabolomics as people are getting onto these multiomics. And we're actually have money from Heart, Lung, and Blood to look at multi-parameter omics on women with preeclampsia. So stay tuned, hopefully. Thank you. Great question.
I think we have time for one more question, so I'll ask a quick one. That was fantastic, Virginia. And what I particularly like about your prediction model that you did is that it's so easily generalizable. You can do this anywhere because you have such simple input data. But one question I have, just because I don't understand it, is it seems that all of the variables, it was sort of a univariate analysis. But if you could do the prediction modeling in a multivariate way, so you can kind of separate out, is it really height that matters, or is it BMI? What's the correlation between hypertension and PE?
Mm-hmm.
And so I don't know if it's possible to do that in the models, and Ivanka may know, and that may be like above your pay grade, but just something to consider.
Yeah. I mean, how I'm understanding the elastic net is it actually is looking at all these correlations and doesn't look at things in a modal manner. Ivana, do you want to jump in and answer? This is the brains behind the project.
Hi, Ivana. So indeed, that was the idea, that we wanted to do multivariate analysis, right? So we put the elastic net or any of these kind of machine learning models have ability to take into account the correlation between these variables, right? As opposed to, so the previous approach is what was typically done was to do univariate analysis to decide which of the variables are significant, and then you put them in the model. We didn't want to do that. So we put everything agnostically. And then the elastic net can take out the correlations. Take into account the correlations. And just one comment to the previous question was that was exactly the idea, that we wanted to develop a simple test, that's like a first test that kind of screens, that's available to every pregnant woman to see, is she at a risk or not? And if then we can identify these women, then they can go through a more, maybe more expensive, maybe kind of test that's based on omics analysis or things like that. So that,
Right. Thank you, Ivana. Great.